How do we have to interpret the presence of contractile lesions after the functional examination? Well, we think of a lesion of a contractile structure. Remember, muscle, tendon, musculotendinous junction, insertion. If one or more resisted tests are positive, then you can think of a muscle or a tendinous lesion. The ideal situation is the one where you have one positive resisted test and your passive tests are negative. You think of a contractile structure. But perhaps we don't know yet 100% sure which muscle it is about, and perhaps we need some accessory test, because there are more than enough muscles with double function. So if you find two positive resisted tests, then this is absolutely not abnormal. Imagine you find three positive resisted tests, then theoretically you could think of a double lesion. That's possible, but rather unlikely. And let's imagine you find four positive resisted tests in your functional examination. Then the first idea is not anymore a contractile lesion, but we think of some other things, which I'm going to explain you a little bit later on. Well, very often we are confronted with tendinous problems. Is it a tendinitis or is it a tendinosis? Well, the tendinitis, a real acute tendinous lesion, is not so frequent. But it's easier to treat and we need less time. The more chronic version, the tendinosis, is more difficult to treat and we take more time. And what exactly is the mechanism behind these tendinous problems? Well, there's a lot of new research available about the actual insights on tendinopathy. And for your convenience, I made a separate chapter on this online platform on tendinopathy. So I refer you to this specific lecture. But at least I can also tell you that still today there is some controversy. Another reason for a positive resisted test might be a fracture. Imagine patella fracture. Well, you're going to find that the resisted knee extension is painful, but also weak. Olecranon fracture. Elbow extension is going to be painful and also weak. Or, let's imagine we do the resisted elbow extension and the patient says, it hurts. Never forget to ask your patient, where does it hurt? And then the patient points to the shoulder and the proximal part of the C5 dermatome. So he doesn't have a triceps lesion. The patient describes pain somewhere in the C5 dermatome. That goes together with a possible compression of an inert structure. In other words, the subdeltoid bursa in the shoulder. And we're going to talk extensively about bursitis in the shoulder course. And we're going to see there that very often we also find that some resisted tests cause some compression on the bursa, resulting in some pain on the resisted test. So this is really very nice clinical reasoning. And as I said earlier, if 4 resisted tests are positive or even more, this is abnormal. Of course, we have to exclude heavy pathology, but often it happens that actually there's a biopsychosocial background. There are psychogenic disorders. Psychogenic patients are never going to say that a test doesn't hurt. Whatever test you do, and you ask to the patient, does that change anything? They're never going to say yes or no. It's always something in between. Yeah? You're not going to have real negative tests. Everything hurts, and this is rather abnormal. The image you see now is quite important, because very important for your clinical reasoning. The ideal situation is number one. Your resisted test is painful, but you don't have weakness. So we think of a small lesion, we think of a small muscular or tendinous lesion. The second situation, on doing the test, there's no pain. The patient may have pain, but the test itself is not positive, but the patient has weakness. Yeah, we can combine that, connect that with a nervous lesion, mononeuritis for instance, or a complete rupture. The third option is a combination of pain during the resisted test and weakness. Your first idea is going to be a partial rupture. But of course, serious lesions like fractures and metastases also are an option. And as I mentioned before, all resisted test positive, look in the psychosocial direction, or perhaps the patient who is quite hypersensitive. So if you find weakness in your examination, the weakness can also be caused by pain, just not because of a rupture or so. No, the best example is an acute tennis elbow. You ask the patient to perform a resisted wrist extension, and you're going to find that this test is quite painful but also weak, but not because of any rupture, just because it hurts too much. And the other reasons for weakness I already discussed with you. It could be a musculotendinous problem, a rupture. Could be a neurological problem, compression on a nerve root by a disc or an osteophyte. Could be a mononeuritis. But it could also be the patient's refusal. Some simulating patients who want you to believe that they have a problem, but in fact they don't have a real problem, they just want 2 weeks of holiday, they could also react like this. So keep that in mind, because this is super important when you are evaluating your test result. Actually, if you want to summarize the orthopedic medicine celiac strategy for the extremities, you can do it just in this slide. You did the history, inspection, functional examination, and then you ask yourself, okay, this patient with shoulder pain, is it a local problem or is it a referred problem? Is it the shoulder or is it the cervical spine? If it is a local problem, what did you find in your examination? Is it an inert problem or a contractile problem? And if it is an inert problem, what did we see in the examination? A capsular pattern or a non-capsular pattern? In other words, remember, arthrosis, arthritis, or other options. And finally, do we know who is responsible for the problems? Perhaps yes. Perhaps not 100% yet. Perhaps I need to do palpation for tenderness in a specific structure. This is the clinical reasoning strategy in the extremities. And as I told you before, in the spine we have a totally different strategy. Actually, how did Cyriax learn his job? Well, an interesting way to come to a diagnosis and a differential diagnosis is to give the patient a diagnostic injection with local anesthetic. You give a specific injection. For instance, you have doubts. Is it an infraspinatus lesion or is it more a subdeltoid bursa? Well, you infiltrate the subdeltoid bursa, you wait a few minutes and you retest. And you see what happened. If you are not in the position to give diagnostic injections, well, there's also an alternative. You can do some friction massage techniques, because one of the effects of the friction massage is going to be an anesthetic effect. Of course, you're not going to friction the bursa, but you can friction the infraspinatus. And then afterwards, you can retest and see if something changed. So that's also an option.